Welcome to this week's Radiology Health for the World Runrounds. Please feel free to introduce yourself and tell us where you're logging in from. And it is my pleasure to introduce our guest speakers for this week, Dr. Jeanne Horowitz and Dr. Viktoriya. And they'll be giving a talk on imaging of obstetrical and gynecological post-operative complications. Dr. Horowitz is an associate professor of radiology at Northwestern University. She's also the director of the Gynecologic Imaging in Radiology and the director of the MR Predominant Body Imaging Fellowship. And Dr. Viktoriya is an assistant professor of radiology with the Department of Radiology at Memorial Sloan Kettering Center, and she is also the director of the Outpatient Imaging Center. We will have a Q&A session after the lecture, so please feel free to add any questions you may have in the Q&A box, and we will address them after the talk. And without further ado, Dr. Peroda and Dr. Horowitz, please take it away.
All right, I will start. Hello, everyone. I'm Viktoriya Peroda. Thank you for that introduction. Thank you for having me here this morning. I will talk about the imaging complications of the post-gynecological surgery in the first part of the talk. So let's start with a tiny bit of history, right? So I want you to all know that you should be thankful that you don't have to consult an Asian gynecologist, because how did we used to treat the gynecological tumors in Egypt in 1800 BC? They were treated with fire, and in Greece, 100 AD, for example, they were injecting olive oil from below for the treatment of so-called tumors. A little bit further on in history, during the Renaissance times, French surgeon and obstetrician Ambroise Paré used leeches to the cervix and recommended uterine amputations for any kind of cancerous disease. Ephraim McDowell, doctor in America in 1809, was actually the first person to remove ovarian tumor in this country. It was nearly 23 pounds. It was done without anesthesia, and he's called the father of ovariotomy. The 19th century doctors, did not go much further. They removed ovaries to cure any kind of female-associated illnesses or so-called, things that attributed to females only. So they cured hysteria and nymphomania or anything else with removal of the ovaries. And the first hysterectomy was actually performed in Germany in 1813 by Conrad Legenbach. So fast forward to today, we live in a different world, obviously, and we have lots of modalities available to us to treat gynecological malignancies. Predominantly, these are treated by hysterectomies or variations of such. Try to do least invasive possible, obviously, to prevent morbidity and mortality complications for a lot of patients. There are vaginal hysterectomies, laparoscopically assisted hysterectomies, robotic hysterectomies, along those lines, and of course, regular total abdominal hysterectomy, bilateral salpingo-oophorectomy, and just a radical hysterectomy without removal of the ovaries. So these are all obviously done depending on the stage of the disease, the disposition of the patient, and also the age and their willingness to try to preserve hormonal function post-surgery. Then for cervical cancers, I'm sure most of you are familiar with trachelectomies, and for just localized ovarian tumors in the early stage, oophorectomies can be performed. Imaging is really an important part of management of gynecological cancer patients, and all modalities are in use. No discrimination here, some more than the others. MRI is heavily weighted. Post-operative complications are mostly done by CT and ultrasound, some on the fluoroscopy, but they're all, all the modalities are very important in management of pre and post-operative gynecological patients. So let's jump into the gynecological post-surgery complications right now. This is a relatively inclusive list, and we're going to go through them one by one. So we'll start with the most simple one, which is not that specific to gynecology, but specific as where it is located. So hemorrhage or hematoma. So this is the most common complication after the GYN surgery. Vaginal vault hematomas usually happens in the first week following hysterectomy. Usually they're small and self-resolving, but if they're large, they are associated with febrile morbidity and need to be addressed. The imaging is easy, non-contrast CT scan, right? So they're relatively hyperdense, it's blood. If there's a suspicion for active bleeding, then contrast enhanced CT should also be introduced. Ultrasound can also be helpful for diagnosis of these. So this is a classical vault hematoma. You could see here it's happening in the upper portion of the vagina. You see that the vaginal vault or is expanded with a high density material on both of these in the axial and sagittal, and this is the classical appearance of the vaginal vault hematoma. Same thing in the ultrasound. So this is vaginal cuff. You could see here that it's expanded. You don't expect vaginal cuff to look like this post-surgery, and it has debris and blood products within it. So this is vaginal vault hematoma. Of course, it could get super infected and can become infected hematoma, but abscesses don't always have to be exactly within the vagina. They could be anywhere around in the pelvis, right? They may communicate with the vaginal stump and drain through the vagina. They may communicate with the adjacent GI tract. For that, we try to do contrast enhanced CT and possibly ultrasound. So here you could see an example of an abscess. There's some rectums here, right, just for orientation. And then here you could see that there is a large collection peripherally enhancing with foci of air. So this is super infected, and this is actually super infected hematoma and adjacent abscess formation communicating with the vaginal vault. Another complication that we worry about is fistula, right? So what is fistula? Just like anywhere else, it's something that connects two things, right? It could be an abscess cavity or hollow organ to the body surface or to another hollow organ. It can be early, but unfortunately, it can also be a delayed complication. It's more common after radical hysterectomies and radiation therapy for cervical cancer because as you imagine, there's a lot of adhesions that could be formed, and that can prevent normal orientation and functioning of structures remaining in the pelvis. And, upon straining or what have you, fistulas can happen. The imaging can be done by fluoroscopy or the diagnostic imaging, or by CT contrast enhanced, MRI contrast enhanced. The more common fistulas that we see is the vesicovaginal fistula, so bladder to the vagina, or rectovaginal fistulas, but you could have any other, intracutaneous, intravesical, intraenteral, intravaginal, or ureterovaginal. So here's an example of vesicovaginal fistula. You can see here that there's contrast material within the urinary bladder, which is communicating with the vaginal vault or vaginal cuff. So this is obviously a fistula's connection there. You may not see the exact communication, but once, of course, you find the contrast in both locations, you know that there is a fistula's connection. Here's another ureterovaginal fistula. So sometimes ureter can be nicked during the surgery. That's why oftentimes they insert the stents into the ureter to identify the ureter and put it outside of the operating field while they're operating to make sure that you don't damage them. But sometimes it gets adhesed and can fistulize. And here you could see that there is a fistula's connection between the vagina. You can see the contrast in the vagina, urinary bladder, and the ureter. Right, and here's the ureterovaginal fistula. Intracutaneous fistula, a little bit more, dirtier complications, so to speak. You could see here that there is contrast material coming out of the small bowel and going into the skin surface. So this could be due to injury during surgery as well as due to adhesions as well. Here's the intracutaneous fistula. You can see here in a fluoroscopy. So just another modality for you for examining this, where the injection is done from the outside and then through the through the catheter, and it's draining, that's draining, and then you could see here that it's opacifying the small bowel loops, indicating intracutaneous fistula. Another fistula is rectovaginal fistula, and this is relatively common. I mean, common on the on the scale of complications. So this is the communication between the rectum and the vagina. Again, you could see contrast in both locations, and here is again you could see that the rectal contrast opacifies, goes anteriorly and opacifies the vaginal cup. Endovaginal fistula, similar idea. This is MRI now. You could see here this is T2 weighted imaging. So this is a fistula between the anal canal and the vaginal introitus. You could see here that there's a clear fistula tract here, and also you could see it a little bit on the sagittal view as well. This is gel within the rectum. Now, other complications of the urinary tract that we should be concerned about are the bladder lacerations, ureteral injuries. And for those, again, the imaging modalities are similar, it's just a different protocol, right? So CT urography, CT cystography, fluoroscopy, and cystogram. So bladder lacerations are usually easily recognized by the gynecological surgeons and corrected at surgery. The risk factors for those are distortions of the pelvic anatomy, just like for most of the complications by adhesions, radiation therapy, pelvic inflammatory disease for some women. Also stage of underlying malignancy, right? Depending on if the tumor is already adhered to the bladder and it's hard to separate, and diabetes. For ureteral injuries, the risk factors, as I mentioned before, is also radical hysterectomy, because they can be injured, and so that's why the stents are inserted. Also, if we have dissection of lymph nodes for malignancy, meaning that the operating field is expanded, so more chance of injuring other structures during the surgery. Direct trauma, of course, to the ureter, and ischemia during stripping of the periureteral fascia, which is also a delicate procedure. Usually the clinical course of these is that they heal without complications, but they could also form urinomas and strictures that would need to be dilated. So here's an example of a ureteral injury with a urinoma formation. You could see here some contrast within the ureter spilling into the urinoma in the pelvis. The next complication that I'm going to move into is the omental infarction. This is not necessarily specific to the GYN surgery. I'm sure many of you have seen this on imaging for various different reasons. But omental infarction should be recognized as it can also mimic other causes of abdominal pain, so things like epiploic appendicitis. Omental infarction is usually larger than epiploic appendicitis. It commonly involves the right aspect of the omentum, where the omentum is most mobile and richest in fat. And to diagnose it, we usually use CT. And on CT, you'll see a triangular or oval-shaped area of heterogeneous fat attenuation, or sort of like mass-like structure of this fat in the right middle or lower abdomen. So here's an example of omental infarction, patient status post hysterectomy. You could see here that there is an omental infarct. It's sort of like a dirty encapsulated fat here. There's no epiploic appendages here to worry about. So this is just omental fat, not to be confused with anything else. And of course, you see post-operative changes here in the anterior abdominal wall. Now, bowel obstruction, again, not very specific, but nevertheless important. Possible complication can be early or delayed. It is fairly obvious that the risk factors are adhesions, just like in any surgery. So they could be due to prior surgery, due to prior radiation, due to the tumor itself, tethering small bowel loops, due to metastatic disease when you're trying to strip the tumor of the bowel. Radical and total abdominal hysterectomies are also risk factors, but that's just prior surgery. Obviously, the imaging is going to be CT with at least the oral contrast or small bowel series. So this is just a straightforward small bowel obstruction. You could see a dilated loop of small bowel with an evidence of stasis. You see some fecalized material within the bowel loop, and narrowing further down. This is, you could see here that there are some adhesions in the pelvis, tethering small bowel here from the prior hysterectomy. Now, the next one, more dire complication, is bowel perforation, right? So small bowel and rectosigmoid are at risk given the nature of the GYN surgery. Actually, the prevalence is similar with laparoscopic or open surgery. Small bowel is just more common during laparoscopic hysterectomy, and rectum coincidentally more common during vaginal hysterectomy. The risk factors for these are adhesions from prior surgery, radiation therapy, pelvic inflammatory disease, and endometriosis. And further complications could be, more perforation, peritonitis, abscess formation, bowel obstruction. Also, we should think about ischemia and fistula. For imaging, we use contrast-enhanced CT. Let's switch a little bit to thinking a little bit differently about this now and talk about abdominal wall scar endometriosis. So this is a direct complication resulting from the a pathological entity itself, right, and the endometriosis related complication. So these can be associated with surgical scarring. It could be in the skin and subcutaneous soft tissues. Implants can end up really anywhere during the surgery, right? Because it gets seated, right? It could happen in the classical ones that we see in the rectus sheath and the muscle at the port sites. They could happen right away, or they could be shown up a few years after surgery. And they can, or it's easy if they demonstrate cyclical pain. The classical teaching is that there's cyclical pain with the endometriosis, but that's not necessarily the case for these implants, and they may present with non-cyclical pain. The imaging ultrasound sometimes can show in good hands hypoechoic mass with cystic and solid components, because these things also hemorrhage, right? With possible internal vascularity, usually peripheral vascularity. On the MRI, these demonstrate variable T1 and variable T2 signal. Ideally, you would like to see it bright on T1, dark on T2, or bright on T1 and bright on T2 to indicate endometriomas, endometriotic implant. And management of these is excision and histopathological diagnosis, to be sure. So here's an example of a hysterectomy scar, endometriosis. And you can see here that, so the uterus is missing, right? So there's some scarring in the lower anterior abdominal wall. It's heterogeneous on T2, right? Darkish. On T1, there's post-contrast, there's enhancement. On T1 pre-contrast, this is bright, right? Relatively bright. And you see here it's enhancing. So this is a scar endometriosis on MRI. And then the next sort of bunch of complications relate to pelvic floor dysfunction. So pelvic floor dysfunction can happen after any surgery, right, in the pelvis. It can also happen on its own with age and, post deliveries, but we talk about the ones that are related to surgery, right? So this is just an abnormal descent of pelvic floor upon straining, right? So the risk factors are total abdominal hysterectomy, because that leads to weakness of the muscles in the context of GYN surgery. And what you can see there is rectocele, cystocele, anterocele, intussusception. Clinically, these patients may present with recurrent UTI, incontinence, constipation, chronic pelvic pain, sexual dysfunction, and frank prolapse. The ideal imaging is MR defecography. I don't know how many centers perform that. Where I am right now, we don't, but because we're mostly, cancer focused, but lots of places do. And this is actually a patient with supracervical hysterectomy. You can see here that the cervix is still preserved, and you can see here that there is abnormal, upon straining, there's abnormal descent of the rectum. You're seeing rectocele here, a relatively easy to detect, right, prolapse of the rectum below. Other more simple complication is lymphocil, right? You see them from time to time from all kinds of surgeries, particularly the one that resect a large amount of lymphatic tissue, post-radical hysterectomy and lymph node dissection, and basically is just leakage of lymphatics because they're susceptible to continuous leakage once they're injured or lymph nodes are removed. They usually resolve spontaneously. When we follow them, you see them gradually, subsiding over the course of postoperative imaging. If they're really large and symptomatic with mass effect, they may need surgical intervention and in rare cases, sclerotherapy. On imaging is easy, CT or ultrasound, and they present as multilocular cystic masses with thin septa. So here's a simple example, again, post-hysterectomy. There's a lymphocil here in the left common iliac region, and that you would just note it in your report and follow it on the follow-ups. And finally, let's get to the peritoneal inclusion cysts. So this is a result of failure of abnormal peritoneum to absorb fluid from the functioning ovaries. Why do I say abnormal? Is because it's been interrupted, right? There was surgery there. It is almost exclusively in the premenopausal women. Again, the risk factors are obvious, and clinically they may or may not present with anything depending on the size and location, or could be just incidentally found on imaging. They may present with pelvic pain, and usually they're not treated with anything. If they're very large, then you can perform fluid aspiration. The imaging modality is CT or ultrasound, and usually they present as a uni or multilocular masses with ideally with ovary in the center. So it's like around the ovary as opposed to at the periphery of the mass, but it's not always easy to detect them that way. So here's an example of a simple perineal inclusion cyst. You see it's like any simple cyst. It will appear as T2 bright, T1 dark, and should not enhance pulse contrast. And obviously it should stay bright upon fat suppression. And sometimes they present a diagnostic dilemma when they are complex, right? And have these, debris and possible septations. And oftentimes sampling is needed to make sure that this is not some kind of recurrent cancer or what have you for these women. So you see here, this one has even has T1 bright signal. So there's some debris and hemorrhage within it possibly, and then T2 bright as well, and it's really large. And you imagine that it can exert a mass effect on the rectum and urinary bladder and cause some symptoms for the women. On that note, I am going to stop and turn the mic over to Jeanne for the remainder of the talk.
Great, thanks, Vicki. That was a really excellent, wonderful review of the postoperative complications after gynecologic imaging. It's so important for treatment. Let's see. Hey, Vicki, can you, or Dr. Proda, can you try to, oh yeah, I think I can't share if the slides are up. I'm gonna share my screen. Yes. And thank you, Dr. Proda, for doing that presentation. Okay, great. So I think you guys should be able to see my slides. So I'll be talking about obstetric postoperative complication imaging as a complementary talk to what Dr. Proder just presented. I'm from Northwestern University in Chicago. So here's our outline of what we'll be talking about today. First, I'll go over imaging of complications after cesarean section. Then I'll talk a little bit about complications after in subsequent pregnancies after C-section, complications from pregnancy termination, and then some complications of sterility and contraceptive procedures. So first, acute complications after C-sections. Hematomas and hemorrhage, bladder flap hematomas are very common. They can occur in up to half of patients. They can also get subfascial hematomas after C-section. That's in the extraperitoneal prevesical space. You can also get broad ligament hematomas or rectus sheath hematomas. Infection is another complication after C-section. CT is very good at looking for abscesses and seeing their location for treatment planning. You know, if there needs to be debridement or percutaneous drainage or surgical drainage. And then also we'll talk about uterine dehiscence, another acute complication from C-section. If you see a bladder flap hematoma greater than 5 centimeters, you do want to be suspicious for dehiscence. Dehiscence is incomplete disruption of the uterine wall with an intact serosa. All right, so here's our first case, contrast enhanced CT images, just after C-section. The C-section was very recent, so think about what you think that is. So this is an example of a bladder flap hematoma. This was post-operative day number 7 after a C-section. This didn't need any surgical drainage or treatment, but here you can see the hematoma between the uterus and the bladder. And this happens where the peritoneum is reflected inferiorly during the C-section. If you see a little bladder flap hematoma less than 4 centimeters, that can be considered normal. Really, if it's a bigger hematoma, that's when you want to get concerned. Okay, here's our next case, another complication after C-section. This patient was post-operative day number 10, and she had a fever. So think about what you think that might be. And you can use Dr. Proder's examples. She showed something a little bit similar, but just not after a C-section. So this is an example of an abscess or superinfected hematoma in the region of the bladder flap. All right, here's our next case. So this is a different patient, 1 week after C-section, and she has a fever. So think about what complication this might be. So this is an example of endometritis. So endometritis is much more common after C-section than vaginal delivery. It can be seen in up to about a third of C-sections after those deliveries. It's a clinical diagnosis. Here we see some gas within the endometrium and in the incision site. And you can see gas normally on imaging up to about 3 weeks postpartum. So just seeing the gas alone doesn't necessarily mean there's endometritis, but it does you do want to raise your suspicion for it if the person has a fever and has that clinical history. And these patients have a risk of septic thrombophlebitis also. So this is that same patient with endometritis. I just want to show you another finding on it. This patient has enlarged ovaries with multiple follicles. And this person also has ovarian hyperstimulation. So this patient started to get induced for their delivery. And that can result in ovarian hyperstimulation and ovarian hyperstimulation syndrome. Most of the cases of hyperstimulation are mild, but some can be severe. So if you see that on your imaging, you do want to talk about it in your report. All right, here's our next patient. This patient had a C-section 2 weeks ago and has vaginal bleeding and sepsis as well. So these are CT angiogram images, so that's why they look a little bit different. You can see we're in our arterial post-contrast phase. So think about what I'm pointing to here. So this is an example of an infected rupturing pseudoaneurysm in a patient with endometritis. So, you know, if you have a patient with postpartum hemorrhage and they get imaging, there are certain things you want to look for on that imaging. So one is a pseudoaneurysm, like in this case. You also want to look for things like retained products of conception, subinvolution of the placental site, or uterine AVMs, which are rare because those things can also cause bleeding on imaging. Uterine atony is another cause of postpartum hemorrhage that's very common, but you won't see any special imaging signs of that. Okay, here's our next case. So this patient, so this is a different patient. She's 7 weeks postpartum, and she still has vaginal bleeding. So these are sagittal ultrasound images, transabdominal, and then a couple transvaginal images. So take a look, see what you think that might be. So this is an example of retained products of conception. So if you see a mass in the endometrium, this one's very echogenic. Retained products of conception can have a varied appearance. A lot of times it is echogenic. Retained products of conception are very unlikely if there's no mass in the endometrium and no fluid, and the endometrial stripe is very thin, less than 10 millimeters. In the presence of retained products, you do tend to see hypervascularity sometimes, but the absence of flow on color Doppler imaging does not exclude retained products of conception. Similarly, if you have a patient that's gotten an MRI exam looking for retained products, sometimes those retained products enhance, sometimes they don't. Same thing, like sometimes they have color Doppler imaging, sometimes they don't. One thing that is important to notice that up to about 50% of patients 1 week after delivery have an echogenic endometrial mass. So that can be normal involuting endometrium or blood clots. It's just that when it persists, many weeks after delivery and the patient still has abnormal bleeding, that's when your suspicion is raised for retained products of conception. Normally the endometrium will thin by 8 weeks postpartum. Okay, so here we've got another case. These are sagittal MRI images of the uterus. So this is sagittal T1 post-contrast and sagittal T2 haste. Now this isn't immediately after C-section. Now we're sort of switching to talking about more delayed complications. So this was actually a few months after the C-section. So what do you think's going on here? So this is a bladder flap hematoma, but the thing is, it's still very large months after the C-section, and this patient has uterine dehiscence. So here you can see sort of a break in the wall of the uterus. There's still an intact serosa around this area of dehiscence. This patient needed this surgically repaired prior to getting pregnant again. So uterine dehiscence can happen after endometritis. MRI is better than CT to try to look for dehiscence. You'll see discontinuity of the myometrium. The serosa should be intact with dehiscence. And treatment, so sometimes conservative management is tried for a partial dehiscence or a small dehiscence. Sometimes if it's a big dehiscence, the patient may need a hysterectomy. Sometimes a small dehiscence can just turn into a little, what we call a uterine niche or isthmocele. So we'll talk about that next. So here's an example of a uterine niche. It's also known as a C-section scar defect or isthmocele. This is seen in up to 3/4 of C-section patients. It's a little defect in the anterior uterine wall. And if a patient's had multiple C-sections, has a retroflexed uterus, or somebody labored before having their cesarean section, they're more likely to develop a niche. And the issue here, most of these patients are asymptomatic, but some are symptomatic. And what happens is you can have menstrual blood accumulate in that niche. So these patients can have intermenstrual bleeding or spotting. Some have infertility. The theory is that sperm might collect in that niche. The risk of rupture in a subsequent pregnancy or sometime later is controversial, but whether it increases risk of rupture. So here's an example of a gross pathology picture of a niche. It's interesting. Some people have studied. I saw a paper studying. Does the shape of the niche matter? And I think the jury's still out on that. I just thought that was a little interesting. So surgical repair of the niche is controversial. Where I practice, sometimes the OB-GYNs will fix that niche surgically if they're doing some other surgery to help improve the patient's chances at fertility, if the patient's having surgery for fibroids or endometriosis, and they also have a niche, they might surgically repair it. And that can be laparoscopic or hysteroscopic repair. But there's no clear role for measuring sort of the myometrial thickness of the niche. It's really not predictive, so we don't put that in reports. Okay, so here's our next case. So this is also a patient who had a remote history of C-sections, 2 different patients. This is one patient with axial and sagittal post-contrast MR images and also a post-contrast CT image. So what do you think about this? So this is an example of adhesions sort of between the uterus and anterior abdominal wall after C-section. So we can see that on MR and CT, even on ultrasound, you might see that the, uterus is sort of looks tethered to that anterior pelvic wall. And the issue here is that the adhesions may result in bowel obstruction. So Dr. Peroder also showed an example of bowel obstruction. This is a patient who had adhesions from a prior C-section. This is a sagittal T2-weighted image of a patient in a subsequent pregnancy. And so here we see all these dilated small bowel loops, and then the transition point to decompressed bowel is right by the C-section, the previous C-section incision site. So that's the cause there. All right, here's our next case, again, sort of a delayed complication. And this one you guys should know because Dr. Peroder showed a very similar case. So we've got some high T1 signal in that anterior abdominal wall right by the pubic symphysis and sort of rectus muscles. It enhances. So this is an example of abdominal wall deep infiltrating endometriosis. If you saw this on imaging, you do want to think about what other differential possibilities there are, something like a desmoid tumor or suture granuloma. Sometimes neoplastic masses like sarcoma, lymphoma, metastatic disease in the abdominal wall could look a little bit similar. But the things that make you think about endometriosis in these cases are, if the patient had a history of surgery at this site, in this case, this patient had a prior C-section. Also, if there's high T1 signal in the mass and some spiculated T2 signal, if it sort of looks like typical endometriosis or has some cystic areas in it. And also they might have that history of sort of monthly pain at that site. Here's another example, again, showing that spiculated T2 signal in abdominal wall endometriosis, some cystic areas as well. On CT, it's harder to tell if it's endometriosis or a different etiology of abdominal wall mass. And same on ultrasound, it's hypoechoic, and you can see there's a mass in the abdominal wall, but unless you have the right history, it's a little bit hard to tell what it is. Here's another example. So this one is a lot more cystic, more multiloculated looking. Okay, so here's our next case. So this patient came in with a non-healing anterior pelvic wall wound 1 year after C-section, whole year after C-section. So what do you guys think this is? So think about that. So this is called a gossipoboma. So this is actually a foreign body that got left behind during an operation. So this is a sponge, and this patient came in because she could sort of reach into this wound and she could feel that there was something there. So that's very bad. So a foreign body gets left behind, in this case, like a sponge, you can get a bunch of different complications, adhesions, encapsulation, granuloma, abscess, fistula. So it's very important to look for. Okay, so a couple other complications in subsequent pregnancies after C-section that we'll talk about. So first, the cesarean scar ectopic pregnancy. So if this is suspected, ultrasound will be performed first. And you want to distinguish a C-section ectopic pregnancy from an abortion in progress, cervical ectopic pregnancy, or low implantation of a normal pregnancy. And the C-section ectopic pregnancies are life-threatening due to the high risk of uterine rupture. This case here is an older case of a cesarean scar ectopic pregnancy that sadly was an abortion in progress. This here that you can see the vagina is filled with hemorrhage. This is that old C-section incision site where the fetus had implanted. And at the point that this MR was performed, it was known that there was fetal demise and that the patient was undergoing abortion. Okay, so here's our next case. So think about what complication this might be. So this patient had an abnormal ultrasound, previous C-section. She's, I think, about second trimester, maybe early third trimester, and had previous C-section. So here we see, so this is the placenta. There's a placenta previa, and there's dark T2 bands in the placenta. This placenta is very lobulated and bulging. Some of the myometrium looks interrupted. There's no myometrial covering over this placenta. It's very heterogeneous. It might be, it looks like it might be sticking out into the perimetrium there. It's a little hard to see. So this is an example of placenta accreta spectrum disorder and placenta percreta. So there's increased risk of placenta accreta spectrum at the site of previous cesarean section. Typically, ultrasound is performed first and is often sufficient to make this diagnosis. On ultrasound, you'll see placental lacunae, loss of normal hypoechoic retroplacental zone, and retroplacental myometrial thinning. Sometimes you'll see irregular bladder wall in cases of placenta percreta. And so the MRI is really only performed when the ultrasound is inconclusive, or if the gynecologist and gynecologic surgeon is, wants it for surgical planning. Sometimes if the placenta is posterior and it's hard to see on the ultrasound. So it's really, the MR is more used for troubleshooting. The ultrasound is first line imaging for this condition. So these are the different signs that you look for on MR. Focal exophytic mass, dark T2 bands, bulging, myometrial interruption. It's very heterogeneous. Sometimes you'll see bladder tenting or bladder wall interruption. And then sometimes you'll see abnormal vascularization of the placental bed, as well as intraplacental vascularity. All right, so we'll look at a couple of pregnancy termination complications. So you could have uterine perforation during DNC. So this is an example of a uterine perforation. This is a transpelvic ultrasound. So this is the uterus. This is a very large 10-centimeter left broad ligament hematoma. And unfortunately, this person had so much bleeding, they required hysterectomy. So uterine rupture is another complication it's thankfully very rare. Risk factors of uterine rupture are prior uterine surgery, C-section, myomectomy, or congenital uterine malformations. Uterine rupture could occur during termination, labor, or before delivery. Usually imaging is not done in cases of uterine rupture because it's so time sensitive. Usually the patient might be unstable. And if imaging is done, it shows herniation of gestational contents, gestational sac contents, like in this case. This is an axial contrast enhanced image that was also done sort of for surgical planning. The patient was stable enough to do the imaging. This is a Foley catheter. Here we can see the gestational sac contents extending out, and so on these cases, there's no serosal covering like in those dehiscence cases that I showed you. And often with the uterine rupture, we see a lot more free fluid in the abdomen near the uterus as well. All right, so what about complications from sterility or contraceptive procedures? So we'll go over a few different scenarios. This is an example of a migrated Nexplanon device. So here's the Nexplanon device. This is a contraceptive device that gets placed in the arm, but in this case, it's much too deep. And the patient wanted it out, so the interventional radiologist removed this under ultrasound guidance. Okay, so here's another patient. Here we've got a trans ultrasound image of the uterus and a trans ultrasound image of right adnexa. So this patient, the history is very important. This patient had an IUD placed 3 years ago. And then she got pregnant. She had a normal spontaneous vaginal delivery. And so this ultrasound is actually after that recent delivery. So what do you guys think this thing is? So that was actually an intrauterine device. So in this patient, I'll go back to the images. This patient, the intrauterine device migrated into the right fallopian tube. You know, it wasn't effective at the contraception. And the patient got pregnant. Anyway, this is another case. This is somebody different where the IUD perforated through the uterus and ended up in the peritoneal cavity. And you can see that all you need is really a single, you know, frontal, abdominal, or pelvic x-ray to see that it's out of the uterus, especially if you already have an ultrasound that shows that there's no IUD in the uterus. So what are some complications of intrauterine devices? There's a higher risk of ectopic pregnancy, IUD expulsion, IUD migration. Sometimes we see these IUDs embedded in the myometrium on CT scans, so I always point that out in my reports if it is, or if it's extending to the cervix. And also if the IUD is left in situ while the patient's pregnant, let's say the patient, you know, gets pregnant despite having the IUD in place, that's associated with low birth weight, premature labor, chorioamnionitis, and spontaneous abortion. So some more risks there. Okay, so here's another case. I think we're almost done. So this patient had pelvic pain, and I'll tell you that this patient had a history of both endometrial ablation and tubal ligation. So think about that. So this is something called post-ablation tubal sterilization syndrome. So this happens in patients that had endometrial ablation and tubal ligation, and some of them have recurrent pain, and what happens is they get some scarring sort of at their cornua, but maybe it's incompletely ablated and there's scarring at the cervix, and so you get sort of tissue obstructing the outlets of the uterus, and then the normal menstrual material can't pass antegrade through the cervix, so it sort of collects within the endometrial cavity, like a hematometra, or you can get retrograde menstruation through, you know, if the tubal occlusion isn't, you know, isn't complete with endometriosis. And so usually these patients have to be treated with hysterectomy and proximal salpingectomy. They have chronic pain. Okay, so I think that's the end of my slides, so I'll stop sharing here.
Thank you so much, Dr. Horowitz and Dr. Perrotta, for the very informative review on the topic. We do have a few questions. Dr. Perrotta answered them in the Q&A box, but I'll just repeat them because some of the attendees may not be able to view them. So the first one is, how do you diagnose urethral injuries?
Oh, you want me to answer them? Just answer them?
Yeah.
Okay,
Yes.
so you can diagnose them several different ways, right? You could do the same way that you would do for any kind of injury, bladder or urethral. You could do retrograde cystourethograms and look for leakage. You could use MRI to look for fistulas, connections, and frank injuries. You could look for collections on CT, which you clue you into the formation of urinomas in the pelvis. So a couple of different ways. You're basically just looking for disruption and any way to diagnose the leakage.
Thank you. And we have been receiving a few messages in the chat box. They've been saying that the lecture was excellent. Great talk. And Dr. Monero, he says, excellent lecture. Congratulations. And then we have one more question. What is the post-operative period to expect lymphocil?
So it starts at about 2 weeks onward, right? So I'd say 2 weeks to 2 months. They usually don't form much later than that. If they don't form, they don't form.
Yeah,
And
but you
then there's
could.
one more question.
Oh,
Sorry.
oh yeah, I was gonna say just just like Dr. Peroder said, right? It might take a couple weeks for them to form, but then they can hang around, in the pelvis for a long time, years.
That's good to know. And then we have one more question. That's in a patient with prior ovarian malignancy post-surgery, are there any imaging features to distinguish tumor recurrence from a peritoneal inclusion cyst?
Okay, so ideally, a recurrent malignancy will have some enhancing components, right? But it's not always easy, right? If you have cystic ovarian tumors, or if the recurrence is small and perineal inclusion cyst is small. So you should look for other clues. Recurrent disease may show up as small peritoneal nodules, subtle peritoneal nodules in other places. You should look for obviously frank metastatic disease elsewhere. And in cases where these things, perineal inclusion cysts are, if they're huge, they're usually perineal inclusion cysts, not recurrences, but let's say they are indeterminate, you will end up sampling the fluid or removing the cyst altogether.
Okay. And I think
Yeah, and also you could you might be able to use the age as a clue also. Like Dr. Peroder said, the peritoneal inclusion cysts tend to be in younger patients, more premenopausal patients.
Oh, and one more thing, the markers. So if you look at for the tumors that are, some of them, of course, again, for the low grade ones, they don't have the markers, but the ones that do have the markers, if the ovarian cancer markers are trending up, then obviously you are more keen on suggesting recurrence rather than something else, or something benign.
Oh yeah, and then this might be a good time to put in a plug for ORADs too. I don't know if you guys have heard of that. It's a new system, kind of standardized way to look at ovarian masses. And so they've even got, I heard at RSNA this year, a new ORADS MRI calculator, but there's a sort of an ORADS on ultrasound lecture. So if a lot of you are used to using ultrasound, it'll kind of describe the different characteristics of how suspicious you should be for an ovarian mass.
Like I put that in the chat box, so if someone is interested in reading it up, they can. And then we have a few more messages. All of them are saying that the talk was excellent. So lots of positive feedback. And I think those are the only questions we have for now. So I think that concludes our grand rounds for this week. Thank you so much, Dr. Horowitz and Dr. Peralta, for sparing the time out of your schedule for the talk. It was great learning from you. And I think that's it. Thank you.
Thank you.
Great. Thanks, Dr. Peroder. Thanks everyone for joining us. Thanks, Abby. Yeah.